Um, at the outset, I would like to sincerely thank Dr. Ramesh Babu because clinical research and publication is something which is sorely missing genetically in Indians. And somehow we always feel that the clinical work that we do is very important. We are rushing and running through it, including me. And publication generally takes a back seat because one, we find we don't have time. Number two, if we have time also, we generally get intimidated by the huge technological terms that is being used. And the moment we send an article for publication, there are hundreds of questions asking about the research methodologies, about statistical analysis, and how did you do, and this and we tend to get bogged down. In effect, finally, our research or clinical paper output is very minimal. This is seriously hampering the science because with our kind of numbers and our type of cases that we have in India, I think it is our responsibility, not just about question of but responsibility to inform the world about what we do and how we do. So the common question comes about how to go about. How do we do it without getting intimidated? How to make the baby steps so that we get little confidence to go further. It is here that I wanted Dr. Ramesh Babu because we had an IAB seminar and he was just so happy because in every step that he spoke about, he put his own publication. He said research analysis. I mean, he put his own publications and he started talking and illustrating. So I'm sure it is going to make the job very well, very easy for people. Let's make it interactive, even if it is slow. I've taken the liberty this time of inviting a lot more people. In fact, all specialties of my department have also spread it across the country, at least to many people, so that more people benefit from this talk. Dr. Ramesh Babu, over to you.
Yeah. Thank you, sir. I hope you can hear me. Thank you, Dr. Ramesh, for inviting me for this talk. As you have rightly said, I'm going to illustrate from my experience of various researches I have done. So if I can do it, definitely you can do it. As you have rightly said, we having the maximum number of COVID cases, we should be the world leaders in COVID publications. We should be telling the world exactly what we should be doing. On the other hand, what is happening is it is the other way around. We are looking at the papers from the West. So in this little talk, I will tell you about how important research is, how important the research methods are, how to go about it, particularly for the young trainees and the junior consultants, why they should do research, why they should not shy away from this thing of research, thinking that this is a very complex thing. If I can do, definitely you can. Now, research for trainees. In India, there is no requirement or guideline for a research to be done by the trainees. Whereas in the UK, it is different. For an SHO rotation in the UK, an audit during house urgency or house officer period is mandatory. So just imagine, instead of having your NEET for MS, you have a requirement for an audit to be done, and then that has to be good quality, and then only you get selected. It is a bit like that. Then basic science research, it becomes a bit mandatory for being selected for a registrar rotation. So registrar rotation means like your MCH training. Imagine instead of a NEET, there is a requirement for research, a basic science research to be done. And then only out of the 20 candidates interviewed, the one who has done a basic science research is the one who is going to get selected for the rotation or the MCH training post, what you can compare it with in Indian setup. So this is what I had to undergo. I mean, this is a animal technology, professional animal technology service certificate. So before doing any basic science research, we have to go through this. We have to get this animal train certification. This is done in proper animal labs. So I did this research in the year 1999, and then this was published in the year 2011. This was under the guidance of Professor Spitz from Great Ormond Street Hospital, London. So only after this, I could get into this registrar rotation. So this is basically like working in the lab. You do not get a salary during the time. You have to apply for a research grant. So the research grant basically funds the research and also the researcher. So we isolate the rats, isolate the hepatocytes, incubate them with palmitate, and then see how much they consume the oxygen with the help of an electrode. And in that, we also add various inflammatory mediators like H2O2, hydrogen peroxide, nitric oxide. And then when we add these inflammatory mediators, the oxygen consumption of the hepatocytes reduce. So that means you can imagine in a liver who is septic, this oxygen consumption is reduced, their performance is reduced. Whereas later on, you go on to add this glutamine. Glutamine, when you add, then they recover. This is a miraculous recovery of their oxygen consumption and performance of the liver hepatocytes. So we add different things like glutamine, glutathione, and various things. And as I said, some people do research for 1 year. I did for 1 year. There are a lot of other local residents who do it for 3 years and they work towards a PhD. They don't mind this, years running out of their running out of years. They don't mind doing it after that PMCA chapter. And they are more particular to know the basics of the research. They are keen to know how a research is done, how a study is analyzed. See, for example, there are various little things like mean, standard error of the mean, then p-value, and then how to represent this. How are you going to learn all these things? They feel this is very important for a clinician, and they spend up to 3 years in this. Now, this research projects in the UK, how it happens is this professor runs a lab parallel to the hospital. So in the next your building, there is a lab, and then there is a series of researchers. It is not just one research. For example, this particular project of glutamine happened over a period of around some 10 years with some 25 trainees. So first one will just do a in vitro study. Then they will look at the markers. Then in vivo studies will be done. So the rat itself will be exposed to hydrogen peroxide and nitric oxide. Then the rat itself will be exposed to various inflammatory mediators, and not the mediators, the infection itself. So the rat will develop a peritonitis, and then the hepatocytes will be harvested. Then the rat will be administered glutamine, and then the rat itself will improve. So then that will go to animal trials. And we now know that glutamine is added to TPN regularly these days. The glutamine is being added in TPN for children because we have done this research 20 years ago that the glutamine is helpful. And it didn't happen overnight. It just happened over a period of several years with so many trainees contributing only a little to this particular research. But the department accumulated the entire research experience. And from that experience, the pharmaceutical companies added this glutamine to the TPN. And now the liver dysfunction following TPN is much less. So this is how it is done. Not like you develop a small drug for coronil or corono and then say that works. That is not how it is done. Now, the other thing I need to do, I told you that the basic thing that you to do is an audit. So you need to know what is the difference between a research and audit. Can anyone, any PG tell what is the difference between research and audit? Can anyone unmute and tell? Sorry, say that again.
Yes, sir. You can continue.
No, I thought somebody will tell the answer to research, the difference between research and audit, the PG or.
Yeah, Vinay, go for it. Vinay, go for it.
Okay, I'll tell.
Research is audit is something whatever we have already done, and we are trying to see what is our outcome. I mean, how much have we attained the normal standards. But research is something. What difference we have brought in, as in.
Okay, I got this slide to summarize. So research is we creating a new knowledge. So we are trying to test a hypothesis, and then we are trying to answer a research question whether a particular an intervention or a treatment is worthwhile, whether it is significantly advantageous compared to another treatment. So we can compare two treatments like a new one and then placebo, or we can compare two operations, or even within one group we can say that this particular technique works. Whereas an audit is slightly different. An audit is like you have an existing protocol, and that protocol you want to know whether it works. For example, you are collecting urine sample by midstream. So you audit all your midstream samples, and then find out that the midstream sample is not good enough, then you change your practice to catheter samples. So you put a catheter feeding tube and then collect the urine. So that is an audit cycle. Or for example, for an appendicitis, you are using a cefotaxime as an antibiotic. Then you audit over here your results of wound infections or whatever infections. And then after a period of time, you figure out that, that the cefotaxime is not good enough. So you want to change it to piperacillin tazobactam. So that is your audit. So audit is a cycle, whereas research is not a cycle. So audit has got a structure, process, outcome, and then you go back to the structure. So you modify the structure or the protocol. So you set standard, measure the practice, they compare the results, and then reflect and plan and change, and then you re-audit. So it kind of it's a cycle. So every year the new house surgeon keeps on doing some audit cycle until that particular system they know that it works. So for example, you have come to a stage where this particular antibiotic works or this particular urine collection method works. Then you go to something else, like you start auditing some other project. So every unit will have plenty of little issues. You yourself may have, this rectal manometry, for example, whether it is working. So you can kind of either see how it is working. So various things, little things, you can audit. But the idea of audit is to inculcate the habit of understanding the research methods, the understanding how the process is done, and various things. Now, being a clinician, a lot of people ask, why should I do a research? So, people in India most often say that we have always done this, we have no problems. Or we say that it works very well in my hands, I don't have to change. Or we say that expert said so. For example, Snodgrass said to do the tip repair, so that is why I'm doing tip repair. So you never bother to see whether it works in your hands. When you actually look only, you will know what has happened. Now, Medical Council of India has set up this criteria. Like, for example, for any academic promotions, you need to have 2 publications at least in an indexed journal, and it should be not a case report, but it should be a series or a proper study, and it cannot be in a paid journals. So this is the kind of criteria that they have looked up. So it does come with an incentive. So when you do a research, you can get a promotion, you can get an increase in salary. So this is a kind of a stimulus to do research. Whether you get a recognition, obviously you can get a recognition. So the recognition is basically so the recognition basically is like for your work. For example, you have done a lot of publications in your field of work, then you get recognized as a particular specialist in your field. Whether it does get patients, that's a totally different thing. But it can sometimes, when your recognition increases, people do refer you patients. But more than that, we don't always have to look at ourselves. So whether it should help us, only then we will do that. Should not be the attitude. We can help the mankind. So we can be a little altruistic, and then we can reveal whatever knowledge or new findings we can have. So this is a typical example of what I say is this in COVID. Somebody tried a chloroquine once. So that is how we know that chloroquine was used. So without somebody publishing, we won't even have used it. Then later on, somebody else tried that the chloroquine doesn't work as well. So that we have stopped using it. So unless somebody tells for the good of the mankind, we won't know. So from the benefiting the man to benefiting the mankind, we should be a little altruistic, and then that is the way to help the people. So if you find something good, why not you share the knowledge? It can be a simple stitch to prevent a dislodgement of central venous catheter. So this we published in the year 2001. This particular surgeon, Mr. Spicer, was doing this stitch. Then I thought, this is a nice technique. Why can't we share the knowledge with the world? Now this is another technique which we published. So during laparoscopic pyeloplasty, how do you put a stent? Whether you put it retrograde or whether you put an antigrade, whether you put it via just pop it in the peritoneum and then try to put it with a lot of difficulty. Then this particular technique via Viris needle was published to just help. Only when you publish that thing, people will know. Then this is a different technique of a distal ureterocystoplasty with a proximal ureter reimplantation. What we are using is we are just using the dilated distal ureters of both sides to augment the bladder, and then bring the rest of the excess ureter back into the bladder. So we are using the native urothelium, and I just out of interest published this, but I've seen several people walking up to me in the conferences and say that I've used this technique. It worked out very well in my hands. This is a nice little modification of if there is excess dilated tortuous ureter, why waste and throw it? Might as well use it to augment the blood. So people do recognize your work, and this is a technique where there is a mini reimplantation for obstructed megaureter. This is another technique we have published. So you can publish anything new or anything little change also which can improve the scientific community. You can share it. Now the common question people get to ask is, how do I get research ideas? So people are interested in research, but they don't know. What do I do? How do I do? How do I? You tell me ideas. The ideas just don't fall from the sky. We have to keep looking for the ideas. So, for example, I'll give you this example. So, I have subscribed to this journals pop-up. So, whenever there is a publication or new issue is released, they will send me an email. So, like these are the articles which has come in this issue. For example, this is an issue on February 2020. So, this is a pretty latest issue. I got this email. Then you don't have to read everything. You just scroll through the title. Then you know that one particular study. So, this particular study is on tolerability and pharmacokinetics and safety of mirabegron. Mirabegron is a B2 agonist, which is used pretty much like our anticholinergic for hyperactive bladders or high pressure bladders or neurogenic bladder or whatever. Now, this particular medicine is relatively new, and then this is having less side effects in the form of constipation or dry mouth, which is normally associated with oxybutynin. Then you suddenly get an idea. Why can't I use this drug? So we have actually applied for an ethics committee approval, and then we are going to start a trial on mirabegron in children with valve bladder. We are also going to study mirabegron on children with dysfunctional bladder. So this is how you get research ideas. Unless you read, you don't. In the past, you have to go and sit and scroll through the journals to get ideas. Nowadays, it comes onto your palm, in your fingertips. It comes to your phone, smartphone. So all you have to do is just read whatever the new journal pop-ups come, and then you can easily get the ideas. So, but before you even start a new topic, you have to be a little aware of certain points. It goes by the research criteria, final research criteria. So it should be feasible. So there should be an adequate number of cases or expertise. So for example, you want to study the outcome of a robotic surgery, you should have a robot. Without having a robot, you cannot study the outcome of somebody else. Then it should be affordable for time and the cost. For example, you're doing a 1-year fellowship in pediatric urology. You cannot do a 1-year follow-up of hypospadias or a pyeloplasty because by the time you would have finished. So you cannot do such kind of studies. You can only do a cross-sectional study or you can do a retrospective study looking at the previous case report. So you have to plan whether the feasibility, but whatever you are doing, it should be interesting. It should be a novel, and the journal will only take it if you are going to add some new finding, or at least it negates some previous finding or confirm a previous finding. You cannot simply do a study and then I expect the journal to publish it without doing a proper homework that it is not already done. It should be ethical, particularly in children. All journals nowadays ask for institutional ethical committee approval. So I suggest that before you even start, all studies, even retrospective study nowadays it is expected, but the prospective study definitely institutional ethical committee approval. It's called IRB, Institutional Review Board number. That is mandatory to be included in your publication. And nowadays the journals don't accept it without this IRB number. So in our hospital, some of our PGs finish the study and then at the end go to the institutional ethics committee and then apply for a number. They won't give. If I am in the committee, I won't give a retrospective approval for something which they have already done. So I can give voice only as a retrospective study. So if you want to do prospective, you come before you start. So that is how it works. Then it should be the knowledge, as I said, it should be relevant to the current literature. So for example, if you want to publish something on sting in VOR, it has already been published 20 years ago. N number of papers are there. You want to say lab fund application is a wonderful technique, you have done some 10 cases. The journal is not going to agree to it because that has been published again 1,000 times. But if you publish a new way of doing lab fund application or new kind of taking a stitch, they might. So we have this formula of formulating a research question. So we have a patient or population or a problem. So what is the population we are dealing with it? What is the intervention for or exposure that a patient is going to get? And what is the comparison? So what is the benchmark or gold standard? And what is the outcome? So you have to define the clinical outcome. So you want to say there is a urethral stricture, you have to define the urethral stricture. You want to say the success following pyeloplasty, you have to define the success. What is the success? More than 10% improvement or improvement in ultrasound? What exactly? So whenever you apply for an ethics committee approval or a research grant, they always ask for these details. They want to know who is the patient, who is included, who is excluded, and what exactly is the exposure, what exactly is the intervention, and what is your benchmark. So they look at all these things, and unless you have yourself thought about it and then answered yourself convincingly, you cannot convince the ethics committee people or the research grant people. Now, one of the common problems people face in India is we are not able to do research. So, why are we not able to do research? So, this is a problem. The main thing is data. You cannot make bricks without clay, and you cannot produce a paper without data. So, here we have this. So, we have started having this database of our patients. We just enter the details in the Excel sheet, and you can see, like, right from the beginning we started, we have this. This is the serial number of the patient, the date, the patient name, everything, what procedure all we have done. So we have kind of developed a system to record it. Now here we also have a sub database. For example, this is all the newborns who underwent primary valve fulguration in our hospital. For example, we have up to 42 cases in 2018. So maybe we have another 10 cases, more 50 cases. So 50 cases of newborn primary fulguration we have. And if we want to study this, we can easily do it. So for example, people say that nadir creatinine of more than 1 is a bad prognosis. This patient came for follow-up, the creatinine has become normal. Not only this patient, there are several patients where the nadir creatinine was more than 1, and then they have all at follow-up pretty much normal. This is at 1 year, 2 year, 3 year follow-up. So this is something which I suddenly think, what is happening here? So is this nadir creatinine, whatever we are saying, that are they doomed patients or not really? So this is something which you can study by simply looking at your database. But whenever you enter the database, you have to make sure, particularly the newborn, initially they had the mother's names, like baby of Nitya, baby of Lavanya, that is how they had the name. Then the patient was named. There is a hospital number, OP number, IP number, then the second IP number. Then they have this mother's phone number, father's phone number. They keep changing everything. So it's very hard to trace them. So unless you have an upfront system to document them all in a database, you cannot go back and either call them or you cannot get the data. Another important problem we have is lack of uniform protocol. What I mean is, when you want to audit something, see, audit can be kind of research. So you have a new system of you should have an existing system to say that whether that system works or not. For example, this publication came in the year 2013 in Indian Pediatrics. So they recommended that any antenatal hydronephrosis more than 10 millimeter needs an MCU, and then if the MCU is negative, we have to do a renal. So any hydronephrosis more than 10 millimeter needs all this evaluation. So this is a protocol which we religiously followed, and then we audited it. So this is our audit of antenatal hydronephrosis using standard protocol. And then we published these results in 2018. So 5 years later, we come up with this paper. And then what we found was we are doing a whole lot of unnecessary MCUs and renograms. So the number needed to treat is more than number needed to harm. So we are doing a lot of procedures. We have now changed to, like for example, only if the diameter is more than 20 millimeter, we do renogram. More than between 10 to 20 millimeter, they invariably 100% become normal renogram, so we don't do it. Similarly, when there is no hydroureter, our pickup rate on MCU for either a valve or a reflex is pretty close to zero. So only when there is a hydroureter, we do an MCU. So we have changed our protocol using this audit. So this is how a protocol. So now what can you publish? The number of studies. This is the level of evidence. Level of evidence for like expert opinions is what people like in editorials or textbook chapters. So these are basically very low level of evidence. Case series and case report. This is what we commonly publish, and this is also a very low level of evidence. Observational studies and comparison of groups. This is a slightly better evidence. Obviously, non-randomized trials and randomized trials come at a higher level of evidence. But at least we should be able to do these kind of observational studies, comparison between groups, and non-randomized trials in our setup. Now, case series, you one day encounter this kind of case, a type 4 completely intrapelvic, sacrococcygeal teratoma. You get so excited and then go about it. I want to publish this. This is so rare, so interesting finding. I never saw a mass outside, and then the patient presented with the constipation. I put a finger, I felt it. So you feel so excited, but when you go into looking into the literature, you will know that already there are some 500 cases of type 4 sacrococcygeal teratoma published already. So you get frustrated when the journal rejects it, but the journal reviewers know that this is already been published. So unless there is something new or something different you have done, they will not publish. For example, if you have removed this laparoscopically, they might publish it. See, this is what happened here. We published a single case report, but basically this was a renal fungal ball treated with a streptokinase. So that was relatively interesting thought. So how a streptokinase can break the fungal balls and then make them excrete it. This was refractory to the antifungal treatment. So we published this, and then this was published despite it being a case report. So you have to be aware that a case report may not be published. Types of studies. Coming to the types of studies, we have this experimental studies, where RCTs and non-RCTs are there. Then observational studies, we have the descriptive studies and analytical studies. In the descriptive studies, we have this case reports and case series. And then we have in the analytical studies, we have a cross-sectional study, case control study, and cohort study. So we have this, these are the common studies which we can do. A case series, we can do a cross-sectional study, we can do a case control study, we can do a cohort study, or we can do a non-randomized control trial also. The case series is the commonest, easiest, and it is often retrospective study. That is the problem with the case series. And it lacks a uniform protocol, and the acceptance rate is very low because unless the information is new, a case series of Hirschsprung's disease, it is not going to add anything new unless you have got something new to say. Okay. Now we published this series of esophageal atresia in neonates with right-sided aortic arch from Great Ormond Street Hospital. Now this was a case series of 475 patients, and there were only 12 patients with the right-sided aortic arch. So although this was a case series, there was some unique information about how to manage this particular problem. So this got published. Similarly, this is a study on chemoports, the complications of chemoport. Now this got published in 2002 because the chemoports are pretty rare or slightly evolving new technique at that time. in 2002. Now 20 years down the line, everybody is putting chemoports. It's pretty common procedure. So if you just want to publish the complication rate of the chemoports, then people will say that this is already published a number of times. So you have to think what exactly the message you want to get. So if you want to get a new message, then that will get published. So before you even start a study, do a thorough review of literature. It may help you to drop your study altogether. It may help you to alter or refine the study, because most of the time at the end of the article, the authors say that in the further study should focus on this particular aspect. That you can take it as a thread to continue. Then you have a chance to get your research published. So ask yourself what is interesting or novel, and then the methodology is the most important part of any study. The inclusion and exclusion criteria has to be very clearly defined. The sample size needed has to be decided with the power calculations, and for this matter you have to meet a statistician up front. There is no point in writing in the limitations that the study is limited by a small number of patients. That is one of our limitation. You know that is a limitation. Why did you then do it then? Why can't you do a proper study? So that will be a question asked by the reviewers. So you always better to consult a statistician. Then as I said, you have to define the outcome. So unless you define the outcome, people will ask you questions. Now, analytical cross-sectional study is a study which is done in the same period with an exposure versus no exposure, or in intervention versus no intervention. For example, this is a study here, functional outcomes of early versus late pyeloplasty. So we have two different kind of approaches to do it. This is another study where comparison of intravesical and extravesical reimplantation. So these are all analytical cross-sectional study. So we just compare the two ways of dealing with it. Then we have this cohort study. Cohort study is or a case control study. The cohort study is like where it's more of a prospective study. So you have a protocol A or protocol B, treatment A or treatment B, or surgery versus no surgery. Then you look at the outcome by following it up prospectively. Typically, a postgraduate student who is taking up a thesis should do this kind of study because they have 3 years to study. So they should do this kind of study. Whereas case control study is an ideal thing for a 1-year fellow. So this fellow has got only 1 year. So he can look at the outcomes which has happened and then go back and say what has been done before. So for example, this is a study which we did comparing F0 diuretic protocol with the F-15 protocol and F20 protocol. So we prospectively enrolled patients into 3 limbs of various protocols, and then we kind of looked at, this was a thesis for one of the PGs. So he found out that which protocol is superior. F0 was superior to those three for whatever reason. So this did it over a thesis period. So that is how a protocol is effective. Now this is a study where we already know the outcome. We know the outcome of a stricture, of urethral stricture following posterior urethral fulguration. So we went back and then looked at whether we used a diathermy or a cold knife. We can still get a good analysis and outcome from a retrospective study. That is exactly the point I want to say. It doesn't mean that because you have a shorter time, you cannot do a proper study. You can still look at the outcome and then go back and then look at the what you did. But in this case, it was a comparison between cold knife and diathermy, and we found that cold knife produces less strictures. Coming to experimental study can be a comparison between a placebo and a drug, or a drug versus drug, or a drug versus no drug, or a before and after a drug. The role of intramuscular testosterone in improving functional outcomes and cosmetic outcomes following hypospadias repair. So this was a prospective randomized study which we performed. Again, this was done by a PG. So this was a thesis for him. This is another study where the effect of tolterodine in non-neurogenic void and dysfunction. This was also done for a PG. This is a prospective study. So tolterodine versus oxybate. So what can go wrong in these studies? So observed association can be by chance. Then there could be errors in data collection. It could be a bias, a selection bias or measurement bias. then blinding is a method to reduce the bias if somebody else measures. Or it could be due to an influence of an additional factor like a comorbid factor. This is a common thing in COVID. For example, a COVID morbidity between India and the Western country. You compare, India has got a more of a younger population. So, your age is a confounding factor here. Now, when you come to publishing an article, the reviewers only grill on the methodology of the paper. So, I will illustrate with this particular study what all we have to undergo. This is the study which I mentioned earlier, the role of intramuscular testosterone. So, when we publish the paper, they ask who is selected. So, we have to say only distal hypospadias. We can't say we included distal and proximal because there is a confounding there. Who was excluded? Redo cases, last follow-up, we have to mention this. What was administered? Intramuscular. It is not topical. So there is no disparity of the absorption. So we have to be clear. How was the response assessed? We assessed using the glance weight, the response to testosterone. Who performed? It will be the same surgeon. So if multiple surgeons are performing, then you are comparing the surgeons also. So what was performed? Tip repair. So if you are doing tip repair, Matthew repair and Magpie repair and all kind of Koyanagi repairs, then you are comparing the repairs. So was it a uniform technique, uniform post-operative care? They want to know all these things. You have to mention that a catheter was kept for 7 days and on the 8th day it was removed, whatever. And then we made sure that people with the catheter only were, the people who removed inadvertently were excluded. So how was the outcome defined? So we have to define what is a fistula, what is a stenosis, how did you diagnose it, what is the glans dehiscence, then the cosmetic outcome, what score exactly you used, then what statistical test was used. So that is in this case we used a Fisher's exact test and student t test. So I think the first part, half of the lecture is over now. The second half is going to be like how to write a paper,
Sir?
how to do a statistical analysis. So at this point we can take a break. We can ask questions.
We have another 5 minutes, sir. So
we will
we'll
only
rejoin.
stop with the questions and then we can go for another day because there is another half of it. Another 40 minutes of lecture is there.
Yes,
so
sir.
that way we can stop here and then ask questions. And then from this particular slide onwards, I will continue in another session.
Yes, sir. So, like you published an audit of your hospital now, sir. Hello.
Yeah, tell me.
Yes, sir. So can we like that publish our audits, sir? Is it as in how is it going to give us a new thing, sir? Publishing an audit is it okay?
No. See, audit. As I said, audit of something very simple. Audit of something very simple like how to collect a urine specimen or what antibiotic prophylaxis may not be having the enough traction. But here we audited a national protocol which is prescribed by the Indian Society of Pediatric Nephrology.
Yes, sir.
So we are auditing something else, not our own protocol.
Yes, sir.
Any other question regarding this particular about how to go about research?
Vinay, most important is the guiding principle about is it adding to the knowledge or value? Is it bringing value?
Yes, sir.
Then whatever it is, it will be published.
Yes.
If it is not, it's not. For example, you say you say that we have analyzed our 15,000 cases of herniatomy. No point.
Yes, sir.
Even though the number is there, it is not adding value. On the other hand, you say that we had about so many cases of which we had direct hernia this much and this is the indirect. So the incidence is this and this is how you can look for as a clue. Yes, it is worth it.
Yes, sir.
So ultimately, anything, it's a message.
Yes, sir.
Now this randomization models, I want to add, there was a question about it. Now there are multiple complex randomization methods like a block randomization and then various different types of randomization. But the simplest what we can do is like you put them into two different groups. So this is a basic study which we are going to do. For example, you want to compare laparoscopic and open pyeloplasty. You want to compare it. Now, you want to put them into two groups means you first find out what is the outcome. For example, it's the success rate. So success rate in pyeloplasty is 95%. So you presume that you have this success rate of 90% for a lap pyeloplasty or 85%. So you have a difference of 5%. So to show a difference, when you do a power calculation, you probably will need 200 patients. That means 100 in each limb. So that 100, how you select is called a randomization. So what you have to do is you have to go to a computer and then enter. There are softwares. The most useful thing in the next talk I will talk about it is how to do the various statistical research. In that the commonest thing I use is this graph pad calculator. You can enter 200 randomize, then it will automatically randomize for like one group 1 2 1 2 1 2 1 2, and then the number serial number 1 to 200 will be randomized. So instead of it will when you look at 1 to 200, it will say like 1 2 2 2 2 1 1 1 2 1 1 1 1 2 1 2 1 2 1 2, like that. There will be no order. It will just put them into 1 or 2. So 1 is open, 2 is left. So that is the commonest randomization we do, and then we can simply do with the computer software which is available in the internet.
Sir, one question, sir. Sir, when we do an observational retrospective study, how important is ethical clearance in such kind of study? Because we are only observing already treated patients.
Absolutely, absolutely. See, this ethics committee approval number, ethics committee, when you apply, they will ask for 100 different things. So this is where we left last time, how to design a study, what are the tools to analyze the data, and how to design a paper. So when you have this starting of this, you have this dilemma of design, what exactly is the design you want to make. Now the designing of the study is very important because you have to ask this question yourself. What is your research question? What is your research hypothesis? And what is exactly you are wanting to prove? For example, you may have a small research question which you may want to convert it into an idea has to become a question. So you have to write down the objective, and then the objective has to be converted into a testable hypothesis. Okay. I am not able to get it into full screen. How do I get this into full screen?
Sir, press the full screen icon, sir, in a laptop or iPad, whichever you. Right lower corner, sir. Yes, sir.
Yeah. So the ideal question one has to pose has got a balance between the data one can access. So before you start even any study, you write down the objectives. It has to be very clear. So the easiest way is to call the junior most colleague in the department and then try to tell him what you are going to do in a simple sentence. Like, I want to look at the difference between the success rate of laparoscopic versus open. So that is a clear objective. Then you translate the objective into a testable hypothesis. So what do you want to? So which is better means, are you looking at the success rate or complication rate, or are you looking at the duration of surgery, or the time to discharge, or are you looking at all of them? So each objective has to be written down, and then that has to be compared with each objective between each groups. So list of potential findings and resulting conclusions. Now, we already discussed this, so I may not go into full details, but retrospective studies are case control studies where you go back and then you have a case and a control. A control in the sense, you may have somebody who has operated as open case, somebody who has operated as a laparoscopic case. You may have the open case as a control. So like that. And then, so that is what is called exposure, not exposure. I mean, that's the outcome basically. Now there is a thing called retrospective cohort study also. I'll come to that in a minute. You have usually the prospective studies are called cohort studies. So prospective cohort studies where you have the exposure at the beginning. See, the exposure means it is like exposure to smoking or not smoking, exposure to laparoscopy or non-laparoscopy, or an intervention A or intervention B. And your outcome can be instead of a case and you can have an outcome like success and failure or disease and no disease. So you need to have it in clear in your mind what exactly is your outcome. So in a prospective study, you have the group selected at the beginning. That is the advantage. So you can select the group, you can select the exposure, you can clearly design the study properly. Whereas in a retrospective study, we cannot select. So the exposure or whatever, the laparoscopy, it's already happened. So it is not at your will, it has already happened. So that is a limitation of a retrospective cohort study or one of those case control studies. Okay. Now this is relative risk versus odds ratio. This is something which you need to know. Odds ratio is like you have this 2x2 table where you have this outcomes is on the top. So the outcome here is the disease. So disease versus no disease. Or in the case of he exposed versus exposed, here again you can change it. For example, if you have open surgery and laparoscopic surgery, success, no success, complication, no complication. So your outcome is here, not necessarily the disease. For example, you have the hypospadias here. You can have proximal hypospadias, distal hypospadias, fistula happening, fistula not happening. So like that. So you need to have your 2x2 table very clearly written. So it's all outcome is always on the what you are testing is the outcome. If you are testing the success rate, that is the outcome. If you are testing the fistula rate, that is the outcome. So the rest of the one comes here. And then the ABCD is ABCD, not the other way around. So once you get this correct, the table correct, you can do your odds ratio. So the odds ratio is what is generally used for this kind of things. So there is a difference between relative risk and odds ratio. The odds ratio is basically the odds of one particular exposure causing a disease divided by the odds of other particular disease causing an exposure. Whereas the relative risk is, it is odds of one particular this is slightly different. This is like relative risk is what I said. So the relative risk is what we normally measure in a patient with a laparoscopic surgery. So you have this relative risk of getting these complications. Here the relative risk of not getting complications. So you have this like that means then you can compare them. So the relative risk larger than 1 means the risk have increased due to the exposure or the laparoscopy or whatever intervention. Whereas in an odds ratio, it is slightly different. The formula is AD by BC. So that is the odds of getting a particular thing. So this is mainly used for medical conditions like, for example, this vaccines. So the vaccines versus the complications. For example, this Oxford vaccine, somebody has been exposed, somebody developed a demyelinating disorder. So that is the odds of developing someone with the exposure with a no exposure. So they will always have a control group where they are exposed to some placebo or no vaccine or some sham vaccine, which is a simple thing. So you have to know the difference. This is a common thing which is used. So both in odds ratio and relative risk, this is what is being measured. But you should always remember how to put it in the table. Clinical trials are really complicated. This is what is happening with the vaccine trials, where you have the two limbs, the experimental and control, and then there is a crossover also. So I am not going into the details. But before you start your study, you have the clear objective, the hypothesis, the research hypothesis, and then write down the outcomes, how you are going to define the outcome, what is defined as a success, what is defined as a failure. So that you decide. Then based on that, you can try to improve your the design by reducing the bias of a different bias, like how you select a patient, how you measure a outcome, all those things you can reduce. Now sample size is an important thing in most of the studies. So for example, we are comparing open versus lap reimplantation or open versus lap pyeloplasty. So how we do a sample size calculation? This is a simple calculator available on the web, internet. So let us say that the success rate of reimplantation is 95% in open and then the success rate is 80% in laparoscopy. So to compare this difference of 15% only, we are looking at the sample size. So our sample size is around 150. So we should have 75 patients who is open, 75 lap. That is how it should come. Now let me change this particular number here. If I change this number, see for example, this is open versus lap pyeloplasty now. I've changed it to 95 success rate for open pyeloplasty and 90 success rate for lap pyeloplasty. Then this number also changes. So because the difference is very small, you need a large number, show the difference. So that is like around 400 patients in each group. So unless you do that many numbers, you're not going to make out the difference. So that doesn't mean that there is no difference. That means that you have not made out the difference. So that is the sample size. Now randomization, as somebody asked last time, so randomization is a way of avoiding a selection bias. So in the previous slide, we saw that we have around some 100, 150 patients required. So those two groups, like 75 in one group and 75 in the other group, we can randomize. So this is a graph pad calculator. So we go into this kind of whatever calculator you want, we go to random numbers. Okay. So then the random numbers randomly assign subjects into groups. And then you enter how many patients, 150. So it randomly selects them into A, B, A, C, A, B, A, like that, A, B, A, B, A, B. So it keeps on assigning 150 patients into two groups of 75. So that is random number. Now, one of the common thing which we measure is this percentage. For example, a success rate or an infection rate. So this is the commonest thing which as a surgeon we represent. So for example, this is a paper which we published in the year 2004. Surgical risk factors for Hickman catheter sepsis. It's a prospective study. So this was came in 2004. So what we are looking at, we are looking at the catheter related sepsis, and that is 9 out of 95 patients, which is 9%. Now for this 9%, it is not enough if I just say 9% infection rate. I have to express it as a confidence interval. The confidence interval for this 9% is 8 to 22%. So how did I get it? That is because I have studied this many patients, the confidence interval is this wide. If I have studied 200 patients, then this interval will be even less, like 8 to 11%. So the wider the denominator is, the narrower the confidence interval. So how do I look at the confidence interval? Basically, I have to, for some reason this is not, yeah. So this is a, again, graph pad calculator. So here I have to go and then select this confidence interval of a proportion. So you have to go to this categorical data. Here I have confidence interval of the proportion. So I enter this 9 and 95, and then that gives the 95% confidence interval. So that means I have 95% confidence that my findings are between these two numbers. Okay. Now the same thing, now we are comparing proportions. So for example, we have a success rate of laparoscopy versus open, or we have a infection rate. So here we compared two different techniques. So here our outcome is infection rate, not the success. So there was a no touch technique where we put a double gloves, betadine gauze all around, and then we never even handled the catheter. We used only forceps to pick up the thing and then put it inside the vein. So this is a no touch technique. The infection rate was around 12%. Now we tried a manual technique. Manual technique means we don't bother. Like you put single glove, but not necessarily don't touch it. You can just handle it. So we want to compare these two techniques. So how do you compare these two? So here you have the infection rate and no infection. So that is the outcome on the top, as I mentioned. And this is the exposure. Exposure means no touch technique or manual technique. So two different techniques. Now here again, when you are entering, you have to be careful. So if it is 4 out of 47, the 4 comes here and 47 comes here, not here. So the total has to be here. So that means 6 infections, 41 no infections, 47 total. So that is how you should enter. So the important I am mentioning is, that is the way of entry is very important. Unless you enter is correct, you won't get the results correct. So here, so when you are comparing two proportions, you are either doing a chi-square test or Fisher's exact test. But if one value is less than 5, then you have to do a Fisher's exact test. So this is a graph pad calculator where we have gone into Fisher's exact chi-square, analyze 2 by 2 contingency table, and then we enter these numbers. When we enter, again we have to enter 641, not 47. Then again 345. So we have to enter the actual outcomes and not the total number of outcomes. And then once we do that, it automatically adds it and then gives the last column here. So you get the p-value. So the p-value is 0.3. That means there is no difference between these two techniques. There is no point in putting extra gloves and whatever. The infection rate is not going to alter significantly. So that is the little outcome of this particular study. Now, as I said, the data what we are analyzing can be categorical data. That means like yes or no, percentage, infection, no infection, success, failure. So that is the usual data we have. Sometimes we have a continuous data, like a serum levels of some hormones or some potassium, creatinine, all those things. Now, these serum levels or hormones or renal function, for example, split renal function. So you have to describe that in the form of a mean or standard deviation. So that for that you need to know if it is a normally distributed set. If it is a normal, you can describe it as a mean and then standard deviation. If it is a skewed data, you have to describe it as a median and interquartile range. So how do you know what is a normally distributed data? So if the data looks like this, it is a normal. If the data looks like that, that is skewed. Of course, we cannot keep on entering the entire data into the bar chart. So there are tests for normality. I'm not going into the depth of the test. Now, the mean and standard deviation are two common things which we use. So how do we do that? Find it out. Excel itself is enough to find out the mean. For example, here I've entered some numbers here. The same set of numbers are entered here also. This is again group 2, where different set of numbers are entered here. So I go to average and then enter here, I get the average. Very simple. Average is a mean. Then again I go into that function, and there is a function called standard deviation. Once I enter the standard deviation, it automatically calculates the standard deviation. So 4.3 is the mean, and then the average standard deviation is also like 2.6. It has come. So that is how it will come. Now when you are comparing the mean, so I entered the two groups. This group has 14 patients, this group has 12 patients, and this mean is 4.3, 2.0. This mean is 7.5, 5.7. So this is a difference. I have also checked whether this is a normal. This is both are normal data. So I can actually use a parametric test. So when you compare this kind of data, what you use is student's t-test. So to compare two means. So here again, we have identified the mean standard deviation and we know the number. So we enter the GraphPad quick calculator, choose data entry format, enter mean, standard deviation and the number. So you can enter mean, you can enter standard deviation, you can enter number. And then from that, you get that this is the mean, standard deviation, number, and then it gives you the significance. So the three-tailed p-value is significant. So this is 0.05 something. It's not really significant. This is kind of not significant, but it's very borderline. So this is a rough data. I entered it for demonstration. This is not a real data. So student t-test is used to compare the means. So for example, we looked at the pelvis cortex ratio. It is a number. So as a marker of success following pyeloplasty. Here we are comparing a mean ratio before and after pyeloplasty. So here we looked at androgen receptor expression in hyperspadias. So this is to compare a hyperspadias score, that H score between hyperspadias and controls. So again, it is a number, it is not a percentage. So we are expressing it in the form of a mean. Here we are comparing utility of ultrasound elastography. So we are comparing the shear wave velocity before and after pyeloplasty. So this is again a number we can compare. So what I want to say is, if you are doing a proportions like a success and failure, you use the chi-square test or Fisher's exact test. And then if you are comparing mean, medians, like a continuous data, you are using a student t-test. That is for a parametric. If the data is skewed, you have to use Mann-Whitney U-test, and then this is best done within SPSS software. Okay. Similarly, when you have more than two groups, like 3 groups, then you have this continuous data. Then that is when your one-way ANOVA comes. Again, it is best done with SPSS software. Then Kruskal-Wallis test is for non-parametric. Again, it can be used to doing SPSS. So these three tests, when it goes to this level, you always seek a statistician. But up to this level, you really don't need a statistician. As a surgeon, you should be able to do it. Now, there is one more thing, testing the usefulness of a test. So, for example, we have a particular test, presence of or absence of ganglion cells on the biopsy. So, that test can be tested here. So, the usefulness of that test, then that is how where we have this sensitivity, specificity, all those things comes. Even here, the outcome is always on the top. The outcome is like a disease is there or disease is not there. And then the test positive, negative. Now, when you write a test positive, test negative, you have to remember, you have to enter it correctly. For example, you are looking for ganglion cells in the appendix. So, the absence of ganglion cells in the appendix is a positive test for this particular Hirschsprung's disease. Whereas presence of ganglion cells, so you have to enter it correctly, you have to think it over. So, you cannot just say that, although it is absence here, you cannot say that that's a negative test. That is pathologically negative, but that is according to our test hypothesis, this is a positive test, positive disease. So, you have to enter that, and then this how to work out the sensitivity and specificity. I am not going into the details of it. Okay. Now, there is one more thing which you need to know. This is called ROC curve. This is being done more recently. This is to find the cutoff for a diagnostic test. For example, you have a linear data, not a yes or no data. So, this is a kidney function test, for example. Kidney function versus pyeloplasty success or outcome. For example, we looked at this postnatal management of bilateral grade 3 to 4 uretropelvic junction obstruction. So, this is we want to know what happens to the kidney function. So, this is we can plot the initial kidney function with the outcome. When we plot it, we get a specificity on one side and then sensitivity on one side. And then this is the point where it turns. So, this is where, so we know that APD of 25 millimeter is a cutoff to say that kidney is going to improve, or a GFR of more than 35 is a point where you can say that kidney will recover. So, you can predict a cutoff for a marker or a particular value. So, you can have a yes or no response like success failure, but you have a varying levels of serum on one side. So, or varying levels of kidney function on one side. So, based on that, you can generate this ROC curve and then look at your, you can predict a cutoff for a success or failure. Now, coming to writing a paper, how to start, you always have the fear of rejection. So, like, how to start, when to start, all those things. Obviously, a catchy title is important, but the title should be a summary of your paper. So, when you write a conclusion and when you want to write that into a single line, like laparoscopy is superior to open surgery in reducing the hospital stay following pyeloplasty, so like that, then that can be converted into a catchy title. So, it is a little summary of your paper. Now, each journal has got a uniform format. It is very important that you read the author's instructions because they have word limit for abstract, word limit for main article, and then they also have limit on the images. So, if you exceed all those things, they are not going to even look at it. So, you have to provide all this information in the title page. So, this IMRAD format you all know. So, you write introduction, methods, results and discussion. Basically, introduction is got 2 paragraphs. So the first 2 paragraphs you have to establish why you are doing this study. So, what is there in the literature, what is not there in the literature, and why what you are trying to do it important. So, you are trying to sell your study, and in the last line of the introduction, you have to mention that in this study we wanted to test this hypothesis that laparoscopy is superior to open surgery in reducing the operative time, or something like that, or discharge criteria, whatever. I am just giving you an example, but the last line should have the hypothesis or your aim. If you don't have it, the reviewers are going to ask you the question. The method, as I told earlier, the method has to be absolutely thorough. How the patients were selected, who was included, who was excluded. then who did what procedure, was it one surgeon or multiple surgeon, and exact technical details. You have to describe the surgery if necessary, if you are doing, or if you are doing some other test, you have to describe how, for example, you are doing a renogram, you have to describe the renogram, how you did the renogram, like was it a well-tempered renogram, was it used with a catheter, was the patient hydrated, so how did you standardize all these things? So those things you have to mention, and then after that you have to also say that what was the, apart from inclusion exclusion factors, after describing the methods, you have to describe the outcomes, like for example what you considered as a success. The success was defined as an improvement in function or by 10% or whatever, or the fistula was meatus stenosis was described as reduced flow observed clinically or on Euroflow. So you have to give a method, or you have to say that the postoperative bladder dysfunction was assessed using a urodynamics with a P detrusor more than 40. So you are describing the outcome very clearly. So unless you do that, they will ask you questions. Of course, for your own design, you should have done it in the beginning. Then the results, what you found in the results, and discussion again. 3 or 4 paragraphs are enough. You're not writing a thesis. So the discussion again starts with a little introduction of why the study is important, but that is not needed in the discussion. The discussion is mainly the first 2 paragraphs, or you are discussing what you found. Like, this study found that this is particularly superior of these findings, and that is why we have found this. Then you have to quote the other studies. This Liu et al. Using that particular study in this year, it said that our findings were, they were concurring with our finding. On the other hand, Simon et al. If we did not concur with our findings, we still feel that this is a useful method. So then in the last paragraph, you try to establish that, this particular, you have to add limitations. This particular study has got certain limitations, like we have low numbers. We have, although we have excluded this particular group, and this is a single institution study or multi-institutional study, or many surgeons are involved, so that could be a confounding factor. But still, these findings are relevant for a future. You should also write a line about how to improve. Like, if the further studies should focus on this particular aspect of this surgery by avoiding such whatever limitation you have mentioned, or whatever improvement you couldn't do, but you think it could be useful in the future. So it should also come out with a suggestion for the future researcher. So if you do like that, obviously the reviewer is going to be absolutely happy, and then he is going to approve the paper. So the introduction is to sell the idea, then the methods is to provide the details, and the results are to expose your data, and then you have the discussion is to discuss the limitations. So as I said, each journal has got a uniform format. Before you concluding after you conclude that discussion, you have to write the ethics committee number, institutional review board number, then funding, whether you got any funding from someone, then whether there is any conflict of interest. Even if there is no conflict, you have to write that no conflict of interest. Then references have to be in the proper style. Usually the Vancouver style is followed. Then coming to figures and tables, I will touch a little bit upon this. Then after that is always given as a separate attachment. It is not part of the Word. So don't put your entire figures into your Word document. But the legends sometimes are usually given in the document itself. So after the discussion, you enter the IRD findings, references, then legends. Then copyright statement and cover letters are separately given. So when it comes to illustrations, it has to be catchy, but at the same time, simple. For example, a simple bar diagrams are very useful. So this is one study where pelvis cortex ratio was used as a marker for success following pyeloplasty. So here we are looking at the mean AP diameter in this chart. Here we are looking at PC ratio, pelvis cortex ratio. So APD is the usual thing. Then we proposed that pelvis cortex ratio is slightly better marker. Then why is it better? Because APD takes 1 year post-op to improve, whereas your pelvis cortex ratio shows that at 3 months itself there is an improvement. So by comparing these two figures, you immediately know that within 3 months you can get convinced that this particular marker can be useful to predict your improvement post-operative. So your idea is to convey the whatever you want to tell in a simple diagrammatic way, and these bar diagrams are pretty useful if you have a parametric data, normally distributed data. When you have a non-parametric data, then you have what is called a box plot. So this is a box plot. So box plot is kind of done use for non-parametric data. This is something where we compare the different pathological markers in predicting the pyeloplasty outcomes in children. Now here, this is a trend. Whenever you want to show a trend, you have to show it in the form of a curve. So this is a trend is always shown in the form of a curve. Now then, something has happened here. Now meta-analysis. Before that, I finished. Yeah. So there are two things which you need to know. During the lockdown period, we completed two meta-analysis. This is a meta-analysis on laparoscopic extravesical ureteric reimplantations. This is a funnel plot. A funnel plot compares the difference in heterogeneity. That means how wide your findings are. So this is something which you can be aware of. I will not go into the details. This is something called a forest plot. A forest plot is where when you compare around some 10-15 studies, you know that this is the average success rate of extravesical reimplantation. So that is pretty much like 97%. But these are the studies which showed more than 97%. So these are the studies which showed less than 97%. So when you give a forest plot, you are comparing the multiple studies. So that is about meta-analysis. So when you come to references, you always have to give from the original source. And when you are writing, it is very important that you write it in your own words. You read the article, but just don't copy and paste the article. Citation manager is something which I use very frequently. The commonest citation manager I use is Mendeley. Mendeley is pretty useful. I can actually put them into different, I can download these articles in this format, and then I can actually put it into different titles, like little folders, hyperspadias articles, DSD articles, so like that. And then I can also have my publications here. So you have to, it's a free software, pretty useful. So once you have a particular citation to be inserted, once you have downloaded these citations, so these citations are all for laparoscopic pyeloplasty here, all these things. So once you come, I have to go here and then say insert citation, and based on the author's name only. See, for example, this is a particular author, Santos. So I have to remember this author's name, go and then type it and then say insert, and then it inserts them. And we can also choose whatever format. If it is a Journal of Pediatric Surgery, that format comes. Now, if the journal rejects the paper and I want to rewrite the same article, it becomes so easy to reformat it for Journal of Pediatric Urology or Journal of Urology or Pediatric Surgery International. So we can easily change the format when you have a citation manager. Now, the common reasons why papers get rejected are it is poorly written. Many people don't know the jargon of writing. The best way is to read more and more articles. You read more similar articles, you will invariably learn how the articles are written. Not as per the journal requirement. And then the research question is unclear. As I told in the beginning, the simple research question is what you want to analyze. Without that itself, we can see a lot of postgraduates doing the thesis without any research question. So by the end of 3 years, these postgraduates want to publish their thesis, but there was never a research question to start. They just looked at a number of patients with whatever, adrenal or neuroblastoma, something they did. What was your research question? What did you want to establish? So that, unless that is clear, people will not accept it. Then methodology again, it still can be retrospective, but you still have to have a methodology, like how you looked at it, what you excluded, what you did not include. Then the results being not valid, extrapolations being not valid. So all those things. Then no clinical application or not a new data. So as I've told in my previous lecture, if your data is already there in the web search, then it's already published a number of times. For example, a deflux. If you're going to write an article saying that deflux is useful for grade 3 vesicular reflux, this is over. The time is over for that. So then the out of scope of the journal. So for example, you want to describe something, an adult procedure done in a pediatric journal, they won't like it, they won't take it. So journals do wait for the right article. Only if a nice article comes, the journal, the reviewers will be delighted. But if they refuse, I won't get frustrated. You have to persist. And then sometimes the reviewers' comments are longer than what you wrote. I've had it. So 4 to 5 pages I write, and then the reviewers' comments come to 6 to 8 pages. So it's no problem. I will sit and then analyze it. I will take it in the positive interest, and then I will rewrite my paper and then send it to another journal. So that is how it should be done. Now coming to the impact factor of the journals. So impact factor means how popular the journal is being read by how many people. Um, Having a low impact factor doesn't mean that the journal is bad, but having no impact factor is not good. For example, pediatric surgery journals and all has got less reader base. So Journal of Pediatric Surgery impact factor is the top journal in pediatric surgery, but still the impact factor is 1.73. Journal of Pediatric Urology is 1.5. On the other hand, Journal of Urology is 5.1. That is because there are many urologists, around 10 times the pediatric surgeons. Lancet, obviously the impact factor is 60. That's because everybody is reading Lancet. So it doesn't mean that you are having a less impact journal, but if you don't have any impact, for example, these predatory journals, then there is no point. Now coming to the last part about the authors, you have become a big author, a lot of articles you have written. Then by registering in Mendeley or ORCID or Scopus, you can have your entire thing displayed in one place. For example, this is the Mendeley. Mendeley comes with something called H index for the authors, like an impact factor. What is the impact of the author? So the number of citations he has had, the number of readers he has got, number of publications he has got. Based on that, they get an impact factor. For example, there is a call for a dean post in one university. They expect an impact factor, or not impact, the H index to be more than 10. So if you have more than 10, they consider for a research post in a dean, as a dean. Then ORCID is something which you have to register right from the beginning, because the ORCID also keeps on accumulating. And there is a thing called Scopus. This Scopus is also Scopus ID is there. There's an ORCID ID and Scopus ID. So those things, as you keep on accumulating articles, you can collect them in one place. That can be a single source of information about you.
The question is, if you have got say hundreds of articles on one sort of a topic, how do
Yes.
you, because you can't read so many articles, how do you judge the worthy article, not so worthy article, or how to go through fast and select which one would be suitable for you?
Now, the way I do is like my topic of interest. So if I have a few topics of interest, for example, hyperspadias or DSD or pyeloplasty. So these kind of articles, I particularly try to read as much as possible. So if my field of interest is suddenly not interested in a thyroglossal cyst, I will not read that. I will straight away skip. But a lot of people read widely. That's different. You can still read widely. But I will first have one or two area of interest of particular year. This year I'm going to research on this. That means this year I'll read more articles on that subject. Among that articles, if I look at the abstract itself will tell me whether I should read that article or not. If the abstract is going to be like very little information, something little new, we still publish. I mean, the journals still publish a lot of previously known information. If nothing is new, then I'm not going to waste my time on that article. I know that data already. If something is new is coming, then I will read about it. As I said, there was recently a publication on role of mirabegron. That is a drug which was used for bladder hyperactivity. So I am interested in that. I am interested to take that project. So then I'll go and then download the full text article, and then I will read exactly how they have done that study, and then I can redesign the study for a different group of either a valve bladder or some other condition. So it will be directly useful for me. That is how I choose it. Is that clear?
Yeah. Thank you.
But we should keep on reading. I mean, even if you don't have any field of interest, these journals these days provide us a chance to register, and then they notify when there is a new issue coming. So when there is a new issue coming, at least you can just go through the, when the pop-up comes, you can just read, and then out of the 10 articles, at least one will be of interest to you. So unless you start reading the full text articles of how the writing style is, unless you know the writing style of the articles and journals, you will not be able to write. The jargon is very important. For example, the common mistake I see when I review articles is like people start writing in the present tense. Articles are always written in past tense. You know what I mean? So we performed this particular test in the years of this thing. We found that this is what it is. We feel that that could be the reason for this particular find. That is how it is. So in many of the thesis also, people should, if they start writing, the PG start writing in past tense about whatever they have done, then when it comes to writing an article, they will keep the same tense throughout.
Thank you very much.
Sir, some research, sir, for example, if we are doing a long-term research for like 6 months or 1 year, can we publish our paper at 6 months and then upgrade it later after 6 months more, sir? Can we do that?
I won't recommend it. I won't recommend it because that is called self-plagiarism, and then I do see that's happening in many centers abroad also. They keep on sending it under different names and different titles with a different article, different journals. But it is not very hard to find it. For example, when we did the meta-analysis on reimplantations, laparoscopic reimplantations, we found that so many papers were repeat publications. This is from USA. So many papers have been published. It was published once with 100 patients in 5 years ago, then 200 patients in 2 years ago, then last year it was published with 500 patients. So what is the point? Unless something has changed, would you keep on publishing something again and again?
Yes, sir.
Sir, I just wanted to know, sometimes getting access to publications is quite difficult, sir, getting access to real articles. So is SkyHub safe, and is it legal, or do we get into trouble when we use SkyHub?
I have not encountered this trouble recently. I mean, I have gone through these phases of getting ability to access articles. We are now in a golden era, to be honest with you. We have so much of pirated articles and illegal websites which are coming up with this free service. I mean, it is not technically illegal in the sense that it is just helping researchers. The SkyHub clearly says that it is helping the researchers. They are willing to take the risk for you. So you are only accessing.
Okay.
They are the ones who are doing it. We are not doing anything illegal by downloading it from them.
Okay, sir.
It's a bit like in the past, around 20-30 years ago, I remember I have to go to library, then ask the photocopying person to photocopy one article from the page, and then the articles will be bound in a thick volume. You won't be able to read the medial most portion because they are all gone into the binding. Then when you keep on going through the articles in the library, the 1985 issue will be there, 1987 issue will be there, the 1986 exactly what you want will not be there. Then we used to write to All India Institute of Medical Sciences asking that people to send the article by Xerox, and we have to send a small amount of money order or whatever. Those kind of difficulties we have gone through in the past. But now everything is available on the internet. We should use it without any hesitation.
Okay, sir. Thank you, sir.
In fact, without these services, this meta-analysis is impossible. During this COVID breakdown, we did 2 meta-analysis, one on laparoscopic reimplantation and one on this disorders of sexual differentiation, gender dysphoria. Both of them will be published soon in Journal of Pediatric Urology. One is already accepted. I'm sure the other one will be accepted. But unless you have a full text article, you cannot, analyze those articles. So whenever you quote a reference, you always try to get a full text article and then read the discussion part, what they have written, read the results, read the methodology. So that will help you before even you start. If you read, then your article, your research, everything can be improved. You can avoid a lot of mistakes which you find in that particular paper. So how to read a paper, how to critically analyze a paper is something equally important. Now, when it comes to this question of rejection of the articles, a lot of people complain that the articles are being rejected. I am also in the review board of several journals, and it is not a really nice feeling to reject articles. I always love to accept articles, but you cannot accept something which will put the journal down. The journal has given you a responsibility to select a proper article. So if somebody is not able to write an article, then you have to help them with so many suggestions. And sometimes it is impossible to rewrite the entire thing for them. If there are a few minor errors, you can always give a big comment and then they can improve on it. But if the entire article is written wrong, including the spelling and this thing, so it is impossible. And the people don't know the structure of an article. That is the main problem. The structure, as I said, that the introduction has got a aim, how to write. Then the discussion has got a way to write. So that particular template is there. Only when you keep on reading articles, you will know. But in the IAPS, we are planning to introduce a manuscript support system. As a first step, what I am planning is to create a template. For example, like a PowerPoint. So like a template, like you will have a template of a Word file where you will have to fill up all these columns. Not fill up a type, you can replace it. It is not like a strict box and all, but at least introduction means you should have this. The discussion means you should have this. So if once you follow that, at least your rejection rate will become less. So I will probably put some dummy article as a template which you can replace with your own text. And the case reports and case series, you please don't depend on them thoroughly because the rejection rate is high.
Yeah. Dr. Ramesh Babu, I'd like to add a few things.
Yes,
Wonderful topic, especially about the publication. I'm also a review board of at least 4 journals, and I also keep articles. What I to people is one, everybody but ask yourself, why your purpose.
Sorry, your voice is breaking, sir.
Can you hear it now?
Yeah.
It now?
Yes.
Yeah. See, most of us are just motivated by the fact that we our publication. We want more number of people to see that there is a publication. But unfortunately, we do not pay importance to the message. I feel most is about the message. What is it that you are trying to convey? Is it new? Is it going to add? I say reverse the whole process. For example, you would be paying for an article to be, what kind of will you read? There is a try to write. Of course, not everybody can come up with an earth-shattering idea, but at least make a point to see that it's worthwhile to add it. Otherwise, it has no relevance to anybody. One. Many times it's very, very poor. You don't need to extraordinary Shakespeare in English, but at least your grammar should be fairly clear. Your letters should be all right. Observation is acceptable. They just so many times it is just written by the junior and senior just sends off. It's necessary for the senior person to review the journal thoroughly and to make sure that a lot of logical errors or presentation errors, grammatical errors can be corrected. 4. As I said, most of the articles are not brief. For discussion is actually A technique of staining for Hirschsprung's versus B's technique, I think they should confine their discussion only to that. Instead, most of them start about Harald Hirschsprung described it in 1864, and then it's not needed. What is relevant to the point being discussed is what it needs to be done. If these things can be done, you are definitely attracting the attention of the editor as well as the reviewer. Any suggestions, comments here? Any other questions?
So in this regard, I want to say something like references. A lot of people come up with references from 1980, 1990. There is absolutely no need. You have enough articles to quote from within last 10 years.
Yes.
If you have properly done a research, if you have properly done a search, even the last 10 years, there will be a lot of relevant articles. There's no point in quoting the first article published on that particular disease because that is so outdated. Number two, a lot of people tend to quote textbooks like from this Arnold Koran or like Mundi, that kind of textbooks and all. You really don't quote in scientific papers. So there's no point. There is a thing called DOI number. So nowadays, when you have these articles referenced, they want it that article abstract at least should be accessible. When you quote your textbooks or conference proceedings, nobody can access it. Nobody can verify that. So all the references should be a verifiable reference, and mostly within last 10 years. Unless it is very crucial, you don't include references which is beyond 10 years old.
Yeah, good point. Good point. Any other questions, suggestions, comments? Yeah, sir. One other practical point which I've got, Ramesh Babu, is even textbook chapters. I've been writing textbook chapters as well as sometimes articles where many times they talk about plagiarism, because what they do is just put an automated plagiarism check, and many times they simply say it is plagiarized. For example, when I say Hugh Hampton described PU valves in 1997, 1905, it is it. I mean, I can't change the words too much dramatically, but it still says it is a plagiarized because it's been taken out from a previous citation, even though I have sort of given a reference to that, saying that, okay, this is what is described in such a book. I mean, how to overcome this automated?
Yeah, see, plagiarism is considered as a serious offense, whether it is taking something from another article exactly verbatim or another textbook exactly verbatim. The sentence cannot have the same commas and full stops and the words. If you jumble the sentences a little bit or you rewrite the sentence with a reference, that will absolutely fine. But only if the sentence is exactly the same, even if you put within inverted commas, it is not acceptable, because that means you have just copied their idea of writing, not only their concept. The concept you can take, but not the wording style. Now our university has got the committee called the Publication Oversight Committee. So before we submit an article, we have to send the article to the Publication Oversight Committee, and they will do a plagiarism checkup. And if they upload it to this Urkund software, and then the plagiarism percentage is more than 15% or 20%, they will reject the article themselves. Acceptable is like something like 15%. Up to 15% is mainly for this kind of common words, like for example, vesicular ureteric reflux, ureteric reimplantation. Those words will be there. Even a sentence like what you have mentioned will be there. So that is up to 15%, 20% is acceptable. But anything above that, they will themselves say that don't publish it, you rewrite it, and then we will access it, and then only we will approve to publish it. So we might as well do it. We can actually upload ourselves. There are a lot of free plagiarism check softwares. So once we upload it, up to 1,000 words is free. So we upload either introduction, 2 paragraphs, and then see which are the lines plagiarized. We can always edit it and rewrite it in a way that the plagiarism goes away.
Okay, but I had a problem because especially this is okay when
Yeah.
you're writing. When you're writing
Now,
a
up to
textbook,
15% is 15-20% is acceptable.
but writing in a textbook, some things are facts. For example, you say Wilms tumor is the commonest renal malignancy. I mean, what can you change? You can. I mean, I can put as a renal neoplasm, but still, sometimes. But of course, this
Yeah. Up to
more
15-20% is okay.
accepted, sir. Accepted.
Now, this paid journals, I want to comment on it. A lot of people think that getting easy article published for the sake of promotions and stuff in a paid journal, this is totally bad idea. I mean, is that your only aim, to get a promotion and better salary? Your aim should be to get it published in a reputed journal. What is the point in paying some money and getting it published? They will publish crap. They will not even review it, and then they will publish it in one day. Even a repeated publications of that matter can be accepted by that predatory. They are called predatory journals. They work for money, so you pay, they publish. But if you send your CV to me with a lot of publications in paid journals, I will put a negative mark for them, because they form a very bad reflection of the person that you are publishing in a paid journal. So it's obvious. So it's better not to have your CV full of these paid publications. It's always better to have your CV with the proper publication.
Agreed, sir. Most of us, unfortunately, lack this P gene, publication gene, and suddenly the medical council tries to get that, saying that now, unless you get a publication done, your promotion is not going to be considered. So everybody is running for a scramble, and this happens. It's just like many things in India. So somehow we feel, as I told in the beginning itself, somehow we don't feel that it is necessary to share the information or publication. Everybody is happy saying that I did it, but they don't want to really publish it somehow. And we're all very happy getting carried away by the clinical work, because I was quite impressed with the way your publications, the range of publications that you had. Very frankly, I was a little ashamed, because all the things that you talked about, I have thought about it, but I've never even cared to put it into publication or maybe even made a research. So it has generally remained as an observation, even for persons like me who is fairly in a good academic position. Still, I'm not able to make as much. So then you can imagine that how everybody else will also be. Anyway, it's a good talk. If any suggestions, comments from anybody, otherwise shall we wind up?
Yeah, thank you, sir.
It has been a wonderful one. As I told, unlocked a lot of potential in others. At the same time, you have set open a new set of Pandora's box. Like, for example, about chi-test and student square test, where to use what, and all those things. Maybe we'll be having a few more sessions with you, including about how to read a paper. All right. Thank you very much, sir.
Thank you.